In 1976, in a small village near a river in Central Africa, people started bleeding. From their eyes, their gums, under their skin. Entire families died within days of each other. No one knew what it was. No one knew how to stop it. Today, that virus has a name the world fears more than almost any other: Ebola. It kills up to 9 out of 10 people it infects in some outbreaks. There is no cure for most strains of it, even now, in 2026. And right now, as you're watching this, a new outbreak is spreading through Central Africa, and the World Health Organization has just declared a global health emergency. So where did this virus come from? Who is really at risk? And can we actually stop it? Stick around, because by the end of this video, you'll understand this disease better than most people ever will. Ebola gets its name from the Ebola River, in what was then called Zaire, today the Democratic Republic of the Congo, DRC. In 1976, 2 outbreaks happened almost at the same time, in 2 different countries, caused by 2 different but related viruses. One in Yambuku, Zaire, near the Ebola River. One in Zaire, Sudan. Both outbreaks killed hundreds of people within weeks. Doctors were baffled. The virus was eventually isolated and named after the river, mostly so it wouldn't stigmatize the actual village where it was found. Since then, scientists have identified several species of the Ebola virus family, including Zaire Ebola virus, the deadliest and most studied, Sudan virus, and Bundibugyo virus, each with different fatality rates and, critically, different treatments available. Where does it actually come from? Ebola is a zoonotic disease, meaning it jumps from animals to humans. The leading suspects are fruit bats, which can carry the virus without getting sick themselves. Humans typically get infected through contact with infected animals, through hunting, handling bushmeat, or contact with bat droppings, and then it spreads from human to human. Since 1976, the DRC alone has had 17 separate Ebola outbreaks, more than any other country on Earth. Symptoms. Here's what makes Ebola so dangerous. It doesn't announce itself right away. After exposure, it can take anywhere from 2 to 21 days for symptoms to appear. During that incubation period, an infected person feels fine, and importantly, they are not contagious yet. Ebola only spreads once someone is symptomatic. Early symptoms look almost exactly like the flu or malaria: sudden high fever, severe headache, muscle and joint pain, sore throat, extreme fatigue. This is actually one of the biggest problems in fighting Ebola in its early stages. Doctors in affected regions often mistake it for malaria or typhoid, which are far more common. That delay in diagnosis can cost lives and let the virus spread further. As the disease progresses, it gets much worse: vomiting and diarrhea, rash, impaired kidney and liver function. In severe cases, internal and external bleeding, the symptom most associated with Ebola in the public imagination. Death, when it occurs, usually comes from extreme fluid loss and organ failure, not primarily from the bleeding itself. Who is most at risk? Let's talk about who Ebola actually affects, because there's a lot of misinformation here. Age. Ebola doesn't spare any age group. Infants, elderly people, and everyone in between have died from it. But historically, most confirmed cases fall between ages 15 and 44, not because the virus prefers that age group biologically, but because of exposure patterns. Adults in that range are more likely to be caregivers, healthcare workers, hunters, or people attending funerals, all high-risk activities. Young children and the elderly, however, tend to have higher fatality rates once infected, because their immune systems are less able to fight the virus off. Gender. This is important to get right. There is no strong biological evidence that Ebola infects one gender more easily than another. What research from outbreaks, particularly the massive 2014 to 2016 West Africa epidemic, has shown is that women were disproportionately represented among cases in some outbreaks. But the reason isn't biological, it's social and cultural. In many affected communities, women are more often the primary caregivers for sick family members, and they play central roles in traditional burial practices, including washing the bodies of the deceased. Since Ebola spreads through contact with bodily fluids, including from a body after death, those roles put women at greater exposure risk in certain outbreaks. Healthcare workers, who are also disproportionately women in many of these regions, face major risk too. So it's less which gender does Ebola target and more which roles in society bring people into contact with the virus. The world's response, then and now, Ebola has shaped how the entire world thinks about outbreak response, largely because of two events. The first was the 2014-2016 West Africa epidemic, the largest and most complex Ebola outbreak in history, spreading across Guinea, Liberia, and Sierra Leone, with cases even reaching the US and Europe. It killed over 11,000 people and exposed just how unprepared the global health system was. That outbreak led to real progress. In 2019, the FDA approved the first Ebola vaccine, Ervebo, effective against the Zaire strain, along with monoclonal antibody, treatments that significantly improve survival odds when given early. But here's the critical current twist. As of 2026, we're in the middle of a new emergency. In May 2026, the WHO declared a public health emergency of international concern for an outbreak in the DRC's Ituri province, which has also spread into Uganda and had imported cases reported as far as France. This is the DRC's 17th outbreak since 1976, and it's especially dangerous for one major reason. It's caused by the Bundibugyo virus, a different Ebola species than the one Ervebo protects against. That means the existing vaccine doesn't reliably work against this strain, and there are currently no approved Bundibugyo-specific treatments. To make matters worse, this outbreak is unfolding in an active conflict zone, with armed violence, population displacement, and cross-border mining and trade routes all making containment far harder. Healthcare workers have already died responding to it. Governments, including the US, UK, and EU, have committed emergency funding, and organizations like Médecins Sans Frontières have opened treatment centers in the region. This tells us something important. Ebola isn't a solved problem from the past. It's an evolving, ongoing threat, and every new strain can reset the clock on what treatments actually work. Coping techniques and health precautions. So what actually works, both for communities in affected regions and for the world at large? For prevention, avoid contact with wild animals, especially bats and primates, in regions with known outbreaks, including bushmeat. Avoid direct contact with bodily fluids of anyone showing symptoms, and with the bodies of those who have died from suspected Ebola. Safe burial practices train teams, not traditional washing rituals, in outbreak zones. This has been one of the single most effective interventions in past outbreaks. Hand hygiene and PPE for anyone caring for a sick person, especially healthcare workers. Avoid non-essential travel to active outbreak zones. Health agencies like the CDC issue specific regional travel advisories during outbreaks. If someone is sick, early, aggressive supportive care is the single biggest factor in survival, meaning fast rehydration, electrolyte management, and treating complications as they appear. Isolate immediately and seek care at a designated treatment facility rather than a general hospital to prevent further spread. For Ebola Zaire specifically, monoclonal antibody treatments exist and significantly improve outcomes when given early. For communities, trust and communication matter enormously. Misinformation and distrust of health authorities have repeatedly fueled the spread of Ebola. Because people hide symptoms or continue unsafe burial practices. Community engagement, not just top-down, medical intervention, is now considered essential to ending outbreaks. The way forward. So where does this leave us? The scientific reality is genuinely hopeful in some ways. We've gone from a mystery, disease with a nearly 90% fatality rate and zero treatments in 1976, to having a licensed vaccine and antibody treatments for one strain. Survival rates, when caregivers get help early, have improved dramatically compared to decades past. But the 2026 outbreak is a reminder of the gaps that remain. We need vaccines and treatments that work across multiple Ebola species, not just one. We need faster diagnostic tools, so outbreaks aren't confused with malaria or flu for weeks at a time. And we need stability, because as this current outbreak shows, a virus is far harder to contain in a region also dealing with conflict and displacement. The bigger lesson Ebola keeps teaching us, outbreak after outbreak, is that infectious disease response isn't just a medical problem, it's a social one. Trust, communication, and community cooperation save as many lives as vaccines do. Finally, Ebola isn't gone. It isn't ancient history. It's an active, evolving public health emergency happening right now in Central Africa. Understanding how it spreads, and how it doesn't, is one of the best tools we have against the fear and misinformation that so often make outbreaks worse. If you learned something from this video, hit subscribe for more deep dives into the science shaping our world. And drop a comment, what disease should we break down next? Stay safe, stay informed, and I'll see you in the next one.